Okay, good morning. Welcome to In the Trenches. I want to give a brief talk this morning. I'm trying to tie it into patients I may have seen in the last day or two. What I want to talk about is type 2 diabetes with severe hyperglycemia. So I have this patient who's in her late 50s who had borderline diabetes along with hypertension. All of a sudden, I get a reading, her blood sugar's 500, and her A1C went up to 11.9. This is new. Okay, she didn't feel well. She was complaining of polyuria, polydipsia. She lost some weight. Okay, so this needs to be dealt with right away, and this sugar is too high to be treated with oral agents. This is not a patient you could put it on metformin or a GLP-1 agonist right away. So basically, you have to treat them with insulin. But with type 2 diabetes, okay, with severe hyperglycemia requiring insulin, really you see this in two venues, actually more than that, but two. It could be at the beginning where it's gone unnoticed and then it presents real high. End stage type 2 diabetes could burn itself out, and then you have to treat it like a type 1 diabetic. Okay, but basically this woman needed basal and bolus insulin to get her sugars under control, and she needed to start checking her sugars and how much insulin you give through different formulas. Now they seem to be starting lower. Back in the day, it would be 0.6 units per kilogram. Sometimes that's an overshoot, and then I heard 0.4 units per kilogram. Okay, but they need basal bolus insulin. And the idea is this: the phenomenon I want to talk about is something called glucotoxicity, where the pancreas isn't dead. It's not like type 1 diabetes or burnout, long-standing type 2 diabetes. It's just the hyperglycemia inhibits release of insulin. So there's a phenomenon I learned about in the 1980s called glucotoxicity. So here's your glucose and here's your insulin. You take anybody who's non-diabetic, or glucose, if your glucose goes up, the pancreas releases more insulin, i.e. you eat, your sugar goes up, you release insulin. You release it until you don't. You reach a point, and somewhere the point's around 150, give or take, and then the high glucose inhibits the release of insulin. We used to call this the horseshoe phenomenon because this looks like a horseshoe. Okay, so the idea is you normalize the blood sugar or get it close to normal with basal bolus insulin, and then the pancreas starts working on its own. Okay, and then you might not need the insulin. You could cut back the dose, you could stop the bolus insulin, and then you could stop the basal insulin, and you could treat them with oral agents. You could put them on metformin, a GLP-1 agonist if they have renal disease, an SGLT2 inhibitor, once in a while low-dose TZD like 15 milligrams of pioglitazone, but you could use other agents. And earlier on in this phenomenon, you could see this, and that doesn't mean they're committed to long-term insulin, at least not up front. And you have to play around with the doses. If somebody's they have a high BMI and they're going to have insulin resistance, giving them real low doses of insulin probably not going to help. If it's a thinner person, that's another story. But what I plan to do with this patient, her sugars are normal now, and I also have her on metformin. And I'm going to keep her on her current dose of basal bolus insulin. Normally half of it's basal, half of it's bolus. She's on 25 units of Lantus at night, and she is on 6 units of short-acting insulin with meals. Keep her on that for another month or two. Keep her on the metformin, and then I'm going to start cutting back. And I hope that her pancreas, will recover, because she'll be sliding back on this curve and she'll be able to release insulin. And then we could get her off insulin. I'm going to wait a couple months before I check an A1C, but it was 11.9. At that level, you need insulin to treat diabetes. So the phenomenon is glucotoxicity, and something that we see. And with that, I'm going to end this. Thank you.